Currently, in most institutions, at least in the United States, every patient that comes in with ischemic stroke would actually get a plain CT scan, would actually get a CT perfusion image and a CT angiogram. Now, there has been an evolving thought that maybe the CT perfusion is perhaps not giving more information than what the plain CTs cannot provide. So I think that there is an evolving thought here that maybe the CT perfusion and the quantitative assessment of CT perfusion is probably not necessary, at least in a certain group of patients. Now, the way the systems are set up, the emergency department cannot make the distinction. It will take too much time to separate who needs the CT perfusion and who does not. So for them, any acute ischemic stroke patient would get the whole protocol. That probably is the most expedient way in terms of triage. So for the CT perfusion as quantitative estimation to not be used, we'll have to say that even in patients that we've used it the most, which is the patients coming between 6 and 24 hours, and patients where you're trying to make the distinction where a large area of the brain has already suffered infarction and revascularization is not a benefit. But I think that there's already an evolving thought here. I think that there's more and more emphasis going on that perhaps CT perfusion and quantitative CT perfusion is something that can be eliminated from this or in the triage pathway. So instead, it should simply be a plain CT scan and perhaps a CT angiogram to demonstrate the occlusion. So I think that as you move forward, one of the implications will be that the diagnostic pathways may be simplified as we go forward.